across here is for those people who had normal blood pressures and for those people who had a short duration of diabetes. That's just the way the data are presented, because in fact all we're seeing is a comparison within this group of those people who didn't smoke. So what we're really seeing here is when you only have one risk factor, being smoking, then the impact of that risk factor is much greater than amongst those people who already have other risk factors, for example, being hypertensive. It's a common observational epidemiological phenomenon. When you add one risk factor to a whole host of other risk factors, the impact is much smaller than when you add one risk factor to no risk factors. And that's really what we're seeing here. But in terms of what we're looking at the moment, this indicates the importance of smoking in relation to diabetic nephropathy. And that may at least be part of the explanation for excess renal disease, probably in the male population across Asia, but seems unlikely to be a major explanation amongst the female population, because in many countries across Asia, smoking amongst female populations is relatively uncommon. Now let's focus a little bit on blood pressure and perhaps suggestions about a greater sensitivity to blood pressure. Here are data published a few years ago from a very large study done across 33 countries. There were actually over 30,000 people from primary care who were studied on a single day. It's cross-sectional data. There were about 24,000 of those people who had adequate data to be analysed. And if we start just by looking at the prevalence of microalbuminuria, and all of these graphs divided up into Caucasian, African, Asian, and Hispanic, we see, as we've seen in other studies, that the prevalence of microalbuminuria was considerably higher in the Asian population than it was in the European and, in fact, in the African population. Somewhat surprisingly, we might have thought, this is not matched by blood pressure. In fact, the blood pressure seems to mirror the risk of microalbuminuria. We expect to see the opposite. We expect to see that the higher the blood pressure, the higher the risk of renal disease. But what we're actually seeing here across these ethnic groups is that the lower the blood pressure is, the higher the risk of microalbuminuria, with the lowest mean systolic blood pressure being seen here in the Asian and the Hispanic groups. But perhaps part of the explanation is what that low blood pressure does to management. Because what you see here is in the lighter bars, the proportion of people on any antihypertensive therapy, and in the darker bars for each colour, the numbers who are on an ARB or an ACE inhibitor, that the RAS blockade, the ACE inhibitor ARB usage, follows the blood pressure pattern. And maybe what's happening here is that because the blood pressures are a little bit lower, there's less use of antihypertensive agents, less use of RAS blockade, and therefore more microalbuminuria. So this may be another contributory cause, that the lower blood pressures are encouraging doctors and perhaps patients to avoid antihypertensive therapy, and particularly to avoid RAS blockade, and therefore to allow patients to develop microalbuminuria. So one might think that, perhaps blood pressure is less important than in Asian populations, but there are some other data that seem to refute that, as one might expect. And here's a recent publication just this year. This is an observational cohort from Taiwan, about 1,200 people, this is a sort of like a STENO2 intervention, except it wasn't a clinical trial, it was a before and after. So there's no control group, but all of the almost 1,300 people with diabetes were put into a program aiming to achieve 6 different targets of diabetes care, involving HbA1c, systolic blood pressure, diastolic blood pressure, and each of the 3 lipid fractions. And the study ran over 4 years, and here you see the incidence of microalbuminuria according to the number of different targets that were achieved. Now, there were 6 targets, and you see immediately from here how difficult it is to achieve targets, because they, in fact, only went up to 3 targets achieved, and there was target achievement. And here you see the risk reduction of developing microalbuminuria associated with achieving each of these 6 targets. And the risk reduction associated with achieving the systolic blood pressure target was far greater than that seen for anything else. So undoubtedly, blood pressure reduction, even though the blood pressure seemed to be somewhat lower, has a major benefit for Asian populations. HbA1c achieving this target only reduced the risk by about 18 or 19%, and depending on which model you looked at in their analysis, that either was or wasn't statistically significant. But the blood pressure reduction the blood pressure target achievement led to a 30 to 35% reduction in risk of microalbuminuria and was highly statistically significant. So no doubt there that blood pressure achievement is beneficial. Just a comment to go back to what I was saying earlier on about adiposity, and perhaps not something that most of us, certainly in our clinical training, had come across, but is being increasingly recognized, is a relationship between adiposity and renal disease. And this has been shown in a number of different populations, and here we see some data from 200 Japanese patients with type 2 diabetes relating CT measurements of visceral and subcutaneous fat with urinary albumin excretion. No relationship with subcutaneous fat, but a modest to weak relationship, but statistically significant, and it remains significant after accounting for confounders, between visceral fat area and albuminuria. So again, maybe what we're seeing here is if this relationship exists, that the relationship might be one in which, rather like we see with metabolic control, that Asian people are more susceptible to modest increases in visceral fat than are European people, and maybe part of the explanation for the increased risk of renal disease. And again, these are data that I think Juliana showed or referred to briefly the other day, but the importance of renal disease is not only in relation in Asian populations to the renal disease itself, but somehow seems to sit more centrally in the development of important complications, and particularly cardiovascular disease in Asian populations than elsewhere. Here we see risk scores for coronary heart disease. Here is the UK PDS risk score, of course based predominantly on white UK population, and this is a fairly standard Framingham type list of risk factors with the diabetes-specific HbA1c added in there. But when we look at a risk score developed in Hong Kong, we see EGFR and urinary albumin-creatinine ratio appearing and therefore being important not only in relation to renal disease itself, but to the development of coronary heart disease. And in fact, when one looks at a total mortality score, again from the same data source, the same registry, where again EGFR and urinary albumin to creatinine ratios appear as important components of predicting outcomes, therefore suggesting that renal disease has a major influence and relationship with the development of diseases other than just kidney disease. So more renal disease and a more important position for renal disease in the genesis of other complications. Now, I'm not going to talk very much about retinopathy, and perhaps one of the reasons is people haven't looked at it very much, and one of the reasons that they haven't may well be that retinopathy does not seem to be something that the evidence, at least at this stage, would suggest is more commonly seen in Asian populations. Here, these are some unpublished data from a large collection of nearly 50,000 people in population-based surveys, looking at the relationship between HbA1c and prevalence of retinopathy, and we see that right across the board, the prevalence of retinopathy seems to be somewhat lower in Asian populations than in non-Asian populations. I'm just going in the last few minutes to talk a little bit about cardiovascular disease and the differences that we see in cardiovascular disease. Here are some data from a New Zealand clinic population that has been followed up for over 10 years, looking at the causes of death in about half of the people who died, and you'll see, as is frequently reported, this very heavy burden of coronary artery disease with a much smaller burden of cerebrovascular disease. And that's not really what we see when we start looking across Asia. Here is Taiwan with far fewer cardiovascular Probably some of this that's called diabetes is also cardiovascular, but we're still considerably less than half the whole population, half the whole cause of death, even if we include all of diabetes as cardiovascular, and the emergence of quite a hefty proportion due to cancer, with a similar proportion in the Hong Kong registry, with about a quarter here due to cancer, and only about a quarter due to cerebrovascular disease. This is probably best described in the Asia-Pacific cohort studies, a collaboration of 24 studies. 19 of them were Asian, Southeast Asian predominantly, and East Asian cohorts, and 5 from either Australia or New Zealand, with over 150,000 participants, followed up for about 5.5 years with a substantial number of deaths. And here you see, first of all, the comparison of the impact of diabetes on all of these different components of cardiovascular disease. And at first look, this seems a little bit surprising, because what we appear to be seeing is that the risk is the same, whether Asian or Australia or New Zealand, whether it's CHD, cerebrovascular, etc., etc. But again, this is a little bit like looking at that slide that we had on smoking earlier on, because this is a comparison of Asian with Asian, and Australia and New Zealand with Australia and New Zealand. And what this is showing is that the impact of diabetes within each of these populations on the different components of cardiovascular disease is the same. When we start to try and separate those and try and more directly compare Asian with Australia and New Zealand, we start to see the pattern that we might have expected. So first of all, looking at coronary heart disease. Coronary heart disease, the mortality from coronary heart disease, whether you're free of diabetes or have diabetes, is considerably lower in Asian populations in the blue compared to the Australian, New Zealand populations in the purple. Similarly, but the opposite way around, for cerebrovascular disease, the risk is much higher in the Asian populations, whether they have diabetes or whether they don't have diabetes, in comparison to the Australian and New Zealand populations. In fact, one also sees, comparing the two, that for example, if we look in the non-diabetics, that coronary heart disease is less common than cerebrovascular disease as a cause of death in Asian populations, whereas coronary heart disease is much more common than cerebrovascular disease in the Australian, New Zealand populations. So fairly clear evidence there that we see far more cerebrovascular disease in Asian populations as their manifestation of vascular disease, and far more coronary heart disease in Australian, New Zealand populations. And in fact, when we saw that, the starting points weren't quite the same. These were just cohort studies. They're not matched. This isn't a randomized controlled trial. And so it's perfectly possible that the baseline risk factors were somewhat different in the two groups, and indeed they were. So the higher risk of cerebrovascular disease deaths in Asians were seen despite the fact that they were marginally younger, despite the fact that the cohort studies had slightly shorter follow-up, and despite the fact that they had somewhat lower blood pressure. So each of those factors are factors that we might have expected to reduce the risk of cerebrovascular disease within the Asian populations. Cerebrovascular disease we more commonly associate with being older. We certainly associate it with needing a longer follow-up, and most certainly with having a higher blood pressure. So despite the fact that the risk factors for cerebrovascular disease were somewhat less in the Asian populations, we still saw more cerebrovascular disease. Once more emphasizing that this relationship between risk factor and disease is almost certainly very different in the Asian population, with a much greater sensitivity to small changes in blood pressure in particular. Just very briefly, coronary artery disease. Do we see a difference in relation to coronary artery disease? Across the region. Here are some data published a few years ago, looking from Singapore, in China, in Chinese, Malaysian, and Indian participants, with the risk being of coronary artery disease, ischemic heart disease, being much higher in the Indian population than in those other populations. And in fact, we recently published something fairly similar, showing the propensity of Indian or South Asian populations to develop coronary artery disease in data from Mauritius. We've got a 20-year follow-up from Mauritius that we recently published data on, showing that the Indian populations, that having diabetes conferred a significantly greater risk of death from cardiovascular disease than was seen in the African population. The Chinese population was probably far too small to make any meaningful comparisons, but we certainly saw a much higher risk amongst the Indian compared to the African population. So, in summary, we have no doubt really that renal and cerebrovascular disease are far more common in Asian populations than in European populations. We don't know an awful lot about why that's the case, but it would appear that the differential risk factors include biological risk factors and healthcare-related risk factors, though the balance of those and the specific weights to be attached to them are not well described. These differences are probably nothing specific to diabetes, but reflect population-wide propensities to develop these particular conditions. And finally, that nephropathy seems to occupy a more central position in relation to the development of other complications than we see in other populations. Thank you very much.
Thank you very, very much for this impressive speech, Dr. Shaw. Actually, I want to ask a question. Do you have any chance to check what's going on before 90s? What I'm mentioning about this, what I'm trying to point out is Asians less tolerant to changing environmental factors? Do you think so?
I guess that is likely to be part of the issue. And for sure, if we went back far enough, we would find that we didn't see an excess of renal disease, and that would be because there was, death from infectious diseases was overwhelming everything else. I think that the likelihood is, though, that in almost any scenario that you care to choose, that the likelihood is that Asian populations will still show a greater propensity towards renal disease. And I think we see it, it's not just in Asian populations, we also see similar sorts of things in Pacific Islanders, and in indigenous populations in Australasia and in North America. So it seems to be a sort of a common feature. Undoubtedly, it has been very overtly unmasked by changing environments. But I think that there is some biological underlying propensity there that we're looking at.
Okay, thank you. Is there any other questions from the audience? No.
Thank you very much for a very comprehensive talk, Dr. Faisal from Sudan. Just have comment or an observation. You showed us the absolute number of patients going into end-stage renal disease is increasing. That means we are not doing very good for our diabetics. But these are absolute numbers. If we compare it among the diabetic population, are we doing any good?
So yes, these sort of global figures are always difficult to interpret, and there are many influences on them. And yes, you might say we're doing very badly with our people with diabetes, or you might say we're doing much better in allocating them the treatment that they already deserved, but we weren't giving them previously. The best data probably, and perhaps the only good data on what we're doing with renal disease is confined to type 1 diabetes. So there are a number of analyses, particularly from Scandinavia, showing that when you look back over the last 30 or 40 years, we're doing a lot better with renal disease in type 1 diabetes. I just don't know that I've seen any convincing data even examining this question about whether we're doing better amongst people with diabetes. It's complicated by many different issues. For example, if you improve your screening for diabetes, you identify a lot more people with what one might call mild diabetes. If you then use that as your denominator for establishing the proportion of people who have a diabetic complication, then the proportion goes down simply because you just went out and diagnosed a whole lot of people with early disease. So there are many things that make that sort of analysis difficult, and perhaps that's one of the reasons why we haven't seen such analyses, and that problem doesn't occur in analysing type 1 diabetes. So I don't know if other people know of such data, but I haven't seen any. It's a very good question.
Another short question. When you break down your Asian population, the Chinese actually form a very large number compared to the other. And that may be making the cerebrovascular complication more than the cardiovascular. Because among Indians, I think the cardiovascular may be more.
Yes. So, terms like Asian are sometimes used rather loosely and mean different things in different parts of the world. And clearly Asia is a vast continent with lots of different manifestations of all sorts of disease. And I sort of hinted at that towards the end, where we saw the much higher risk of coronary heart disease in Indian populations, and that certainly seems to be a well-established observation.
Enjoy your talk
Excuse
and
me,
also
I'm
your
sorry,
debate.
we passed already 2 minutes to other speech, though. If you can ask your question later, I will appreciate that. Thank you. Thank you very much, Dr. Shah.
And this afternoon, we have a very interesting debate